All right, so valves. We're going to look at valvular regurgitation and valvular stenosis. And so I used to really go crazy with this, but I realized that it wasn't really necessary. So valvular regurgitation is also sometimes referred to as valvular insufficiency or valvular incompetence. And then there's stenosis. So we know we know the valves, right? We know that there's the right and left AV valves, or the tricuspid on the right, the bicuspid on the left. The bicuspid oftentimes and probably most commonly is referred to also as the mitral valve. Those are the ones with the valve leaflets that are attached, that have chordae tendineae, which attach to the inner wall of the ventricles via the papillary muscles. The papillary muscles are only found in the ventricles. The chordae tendineae are only found on the AV valves. And then we have the semilunar valves, which one is the pulmonary semilunar valve, or many people just say pulmonic. And then there's the aortic semilunar valve, the one on the left side, which probably you'll just say the aortic valve, which you can't really see here because it's kind of tucked up in this medial and superior. So it's kind of up in here. All right, so the job of valves is that they ensure that blood flows one way and flow should not be impeded. That's key. For everything to work effectively, the flow needs to be one way and the flow should not be impeded. So another thing to note is that we can see, and often do see, regurgitation and stenosis in one valve. So you can have both a regurgitant and a stenotic valve. So the term regurgitation essentially is referring to backflow. When you have a regurgitant valve, the blood is not going one way, it's moving the wrong way. In many cases, it's going two ways. So remember when we talked about heart failure, I mentioned functional regurgitation of the mitral valve is where it starts, and then it carries on over to the tricuspid valve as this gets more and more progressed. So when a regurgitant valve, the blood in this case is not being contained in the ventricles, and instead some of it is flowing back up into the atria. So that's regurgitation. Stenosis denotes narrowing of the valve. So it impedes the blood flow through the valve. So with regurgitation, the blood is going backwards or the wrong way. With stenosis, the blood flow is impeded. And like I said, you can have both stenosis and regurgitation in the same valve. You don't have to have it, but you can. So what we kind of want to, the question that starts to get important is to ask, how is this affecting the heart? So we see when there's backflow, we're going to have an increased volume of blood in the chamber that's receiving that blood that's moving backwards. So if the mitral valve was regurgitant, then the left atria, would be receiving some of that blood. So the volume of blood in the left atria would be higher than it would be otherwise. So the left atria then is responsible to pump an increased volume. So the burden in this case is put on the left atria. If the aortic valve was regurgitant, then the burden would be placed on the left ventricle. That volume of blood is increased. And then when you have an increased volume, you can also see an increased pressure. But at first, it seems to be more of a volume issue. It kind of can follow a continuum. Now, with the stenosis situation, where you've got this narrowed opening, the chamber that's pumping into the stenotic valve, or through is a better term, I guess, the chamber that's pumping through that narrowed opening has to increase pressure, right? You have to push harder to pump through a smaller opening. So if we had, again, with our example of the mitral valve, and I use the mitral valve on purpose because that's the most common valve problem, right? Mitral valve issues are the most common valve issues. So if we have a stenotic mitral valve, then the left atria has to increase the pressure to pump past that narrowed opening. If we have a stenotic aortic valve, then the left ventricle has to generate more pressure to overcome that narrowed opening. So I think it makes the most sense to sort of think about what's going on and how that's actually affecting the heart. So if we were to boil it down to like the most simplistic sort of approach, we could say regurgitation results in a volume problem, stenosis results in a pressure problem. But as we've said, oftentimes they coexist, so we have both a volume and a pressure problem. We've seen this picture before. This is just showing us the fibrous skeleton of the heart and the 4 valves all in that plane. Okay, so without going through crazy with this, I used to go crazy with this, and it was like ridiculous. But we want to think about some of the physical issues that can cause valvular regurgitation and valvular stenosis. So we'll go through kind of a list. Physical sorts of structural issues. So we will get regurgitation when the valve doesn't shut properly, right? That's the biggest thing here. So there could be an issue with the cusps, the valve cusps. They could be shrunken, they could be pulled back, they could be retracted. They're not going to close effectively. There could be an issue with the chordae tendineae. Sometimes the chordae tendineae will shorten, mostly because of scarring, and that will keep the leaflets from meeting. The chordae tendineae can rupture, and then we've got the leaflets kind of like just flapping along. They're not anchored at all. The papillary muscle issue, we saw this before in that picture with that big chunk of papillary muscle just not adhered to anything. That's going to cause a major regurgitant valve along with a whole bunch of other issues. In these cases, the complete valve everts into the atria, or into, well, it only happens with the AV valves. And then our kind of functional regurgitation, if the entire valve orifice enlarges, then the valve doesn't shut. So those are some options, some structural issues. Here's a few pictures of damaged valve cusps. This is usually the result of like some post-infectious situation where there's been scarring, which is quite common. Here we've got, see this little papillary muscle, bing, right? It's just flapping. So that's going to cause a regurgitant valve. This is functional regurgitation. We've seen this picture before. That heart is huge. Those valves are never going to shut all the way. All right, then we have stenosis. So what can happen here, right? This is pressure. This is the pressure one. This is where you've got a narrowed opening. So the valve cusps can really thicken and stiffen would be another good use of the terminology here. This can be due to scar tissue. They can become calcified, which makes them really, really thick and stiff. The valve leaflets can fuse. This happens oftentimes secondary to like endocarditis, which I'll show you a picture of in a little while. Right, there's an infection, like a bacterial infection, and the lesions are that particular microbes particularly has a particular affinity for the heart valves. This is like a rheumatic fever, post-rheumatic fever. This is common, and then they get these lesions on the heart valves that heal over time. But what happens is they get a bunch of scar tissue, and the valve leaflets can actually fuse. And I'll show you a picture of that. Kind of along the same line, the chordae tendineae will also oftentimes fuse and or thicken. So let's look at some pictures. So this is really, really thickened cusps and fused chordae tendineae. See how they're just all adhered to one another? So that's a lot of scar tissue. Here we have the leaflets are actually fusing together, right? So they're not going to open effectively at all. All right, so let's think of 4 factors, and there's not only 4, but we're just going to identify 4 factors, etiological factors that can cause valve disorders. I've alluded to this one already, rheumatic damage. So this usually will get worse. This is usually after a bacterial infection, most notable with strep. We also see bacterial endocarditis, and with bacterial endocarditis, the bacterial endocarditis is confined to the external lining of both the valves and the chamber. A strep is a known one here, along with micrococcus and staphylococcus are another organisms that are known to cause this particular kind of infection in the heart. Myocardial infarction can cause papillary muscle dysfunction, as we talked about previously. And then there can be congenital malformations, which are things that have been there all along. You can have a congenitally malformed valve. This is oftentimes one of the very uncommon, but I should say, sorry, my brain is getting tired. When you have right-sided heart failure, which is not common in the absence of a left-sided disease, the most likely cause of that is a pulmonic valve issue. And so oftentimes you have a congenitally malformed pulmonic valve, and that generally gets caught relatively early. But you can have congenital malformations of either the papillary muscle and the chordae tendineae also. All right, so let's look at some pictures. So this is what rheumatic heart disease looks like, heart damage looks like kind of early on, right? This is still pretty active. You can tell this is an actively inflamed region. And you can see, so this is the valve, right? This is the AV valve. And these are the chordae tendineae, right? And so you can see how this can ultimately lead to that picture we saw when we first looked at those fused and thickened leaflets and chordae tendineae. So all of this is all infected and inflamed. And what's going to end up happening over time is this infection is going to resolve, ideally, and they're going to end up with scar tissue, which is going to get worse with age. So ultimately we'll end up looking like that. So you can see, just by looking at that, you can appreciate how dysfunctional that valve is going to be. This is a congenital pulmonary stenosis. Again, the pulmonic valve is the least likely to be problematic, but it is, and if it is, it's most oftentimes congenital. Sort of the rule of thumb, I think it will come up, is, oh yeah, here it comes. The valve, we're going to list the valves in order of increasing frequency of malformation and discuss the likelihood of single or multiple valve disorders. So this is sort of the rule of thumb, the valve problems in order of frequency. The bicuspid before, so we usually say left before right, mitral before aortic. So the left side of the heart is, so left side of the heart before the right side of the heart, and the mitral valve before the aortic valve. So the most likely valve problem is going to be found in the bicuspid or the mitral valve, followed by the aortic valve, and then we go to the right, and it would be the tricuspid, followed by the pulmonic or the pulmonary. So left before right, mitral before aortic. Okay. So I'm just going to talk a little bit about a few of these that are more common. So mitral stenosis, again, this is a situation where we have impeded blood flow from in this case, because it's the mitral valve, from the left atrium to the left ventricle, which causes the left atrium then it has to generate more pressure to fill the ventricle. So it's a pressure problem, and the left atrium shouldering the burden. So in response to that, the left atrium will hypertrophy to increase the pumping force against this narrowed valve, the stenotic valve. So the left atrium will dilate. This will increase left atrial pressure and the volume in the left atrium because it's not able to get all the way through. And then that gets reflected backward into the pulmonary vasculature. So these people are going to have pulmonary symptoms pretty early on with mitral valve issues. Okay, then we think of mitral valve regurgitation. So now what we have is backflow or retrograde flow from the left ventricle to the left atria because the valve isn't closing completely. It's an incompetent valve closure. So during contraction, the left ventricle ejects blood forward into the aorta, which we know, and also backward into the left atrium. Really, when the heart just starts to enters into that systolic period, blood will start to regurgitate back into the left atrium. So this one, this one is kind of interesting because we've got sort of two things happening. First, we have an increased volume of blood in the atria because of the backflow, so that puts work on the atria. But then what we're going to end up getting is an increased work of both the left atria and the left ventricle to preserve cardiac output. So we're going to elicit those compensatory responses, which are going to, try to be elicited to maintain cardiac output. So we'll see the hypertrophy of the left ventricle, then we'll see hypertrophy and dilation of the left atria. I don't know that we could say for certain that one happens before the other. It happens. Both of them will hypertrophy, and the the dilation really is just in the atria because of the volume issue. The hypertrophy is more against the pressure, dealing with having to generate more pressure. I'm showing you, for some reason, I don't know why I decided to show you this picture again, ruptured chordae tendineae. I don't know why I put that there. I'm sorry. I guess I was just trying to illustrate a regurgitant valve. Okay. Oh yeah, that's right. I'm sorry. We're talking about the left atria having to the problem with the left atria is it's not able to really distend so much because it doesn't really have a lot of it's not that stretchy, right? It doesn't have that much tissue. It's non-compliant. Okay. Sorry. All right, let's talk about aortic stenosis. So here we have a stenotic valve, a narrowed valve that's getting in the way. It's impeding blood flow from the left ventricle into the aorta during ventricular systole, because we're looking at the aortic valve here. So aortic stenosis, the left ventricle has to push harder against that stenotic valve in order to eject the blood during that period of systole. So the pressure work is of the left ventricle, and it will hypertrophy, and the walls oftentimes become quite stiff. It's kind of curious here. Well, I mean, it shouldn't be curious, but it's good to note that the symptoms are later to develop, and the symptoms here are things that you're going to notice. The thing that you're going to notice, the symptom that nobody is going to miss, is their lungs filling up with fluid, right? So that's not going to happen right away here, because the issue is kind of far away from the lungs. It will happen eventually, but it's not going to happen until the heart has actually failed. So the symptoms are late to develop. So the symptoms correspond to, a really significant decrease in the orifice of the valve. So from 3 to 4 centimeters squared roughly to less than 1 centimeter squared. That's where the symptoms develop. So this is kind of what a stenotic valve looks like. It looks like there's some lesions on this valve as well. But this is kind of the, it's stiff, it's narrowed, it's not going to work very effective. All right, so we're just going to really quickly compare the pathological progression of mitral versus aortic valve disorders and discuss quickly the use of drug therapy versus surgical intervention. And since we don't really talk about drugs, it's going to be sort of a theoretical conversation. So the mitral valve, remember the key here, symptoms are going to show up earlier, because the problem is nearer the lungs. That's really the deal. And because the symptoms show up earlier, there's a bigger window for treatment. So we can start with drugs before we have to really go in there and replace the valve. And some people, it sort of depends. There's lots of degrees of mitral valve disorder. Some people don't, they have a slightly regurgitant valve, like a mitral valve prolapse. You've probably heard about that. It's very common. People show up with a heart murmur, and the reason why they have a heart murmur is because their valves don't close all the way, and the sound that we hear when we hear the heart sounds are the sound of the closure of the valves. So if the valve doesn't close crisply, then there's a murmur as a result of that. So if somebody hears a heart murmur, then it's a very good indicator that there's a valve issue. It doesn't tell you what it is. It just tells you there's something not right. So this happens early, and they can be treated with drugs. And my point was, that people with just a minor mitral valve prolapse most likely aren't going to be treated with anything. They're going to be kind of watched. As it gets more and more significant, then they are going to be treated with drugs, and then maybe potentially valve replacement. But they've got a long time here. And the issue is that the ventricles are really not in that big of a danger. So surgery is reserved for when the cardiac output actually fails, because at that point the heart has failed. So you might argue, oh, maybe that's a little too late. And I think that would be a reasonable argument, but that's kind of the way it goes. Now, the aortic valve situation is more of a challenge because it's further away from the lung, so there oftentimes aren't any symptoms until the heart has failed. That's the first symptom. And so that really paints us into the corner in terms of management. So they'll generally try to get in there ahead of time and get surgically replace the valve before you actually get pulmonary congestion. So, that's not hard and fast, and there's definitely room to sort of take things on a patient by patient basis there, but that's kind of the rule of thumb. All right, I think we can call it a missed lecture. This has been long. My brain is completely fried. I'm sure you guys, hopefully you're spreading this out and not doing this in a marathon session. But that's about 3 hours, I think. So we will pick this up with arterial disease, and then we'll do we'll talk about arterial disease, we'll talk about venous disease, and we'll talk a little bit about hypertension and shock. And I think that will more or less wrap us up for the cardiovascular system. So with any luck, we'll actually be able to finish this and start the respiratory system next week. So remember, you have 2 homework questions to work on. I'm not going to have them due until after we meet again, just to remind you. But the homework question 2 was the stroke volume one, and you were going to discuss the 3 variables, one of which was preload, one of which was contractility, and the final was afterload. And then the 3rd homework question was to discuss the pathological progression of heart failure. Left heart failure, you are going to want to kind of talk about the forward failure and the backward failure, even if you don't want to use those terms, how the body responds to the decrease in cardiac output, and then how the body responds to the failing left ventricle. And you're going to carry that through all the way from the left side of the heart to the right side of the heart. And if you want to continue into the systemic circuit, that is okay as well. Okay, have a wonderful holiday weekend, and I will see you guys on Thursday night.